So thank you all so much for joining us today. We are going to be talking about the genetics of NAFLD and NASH, but we're also going to touch a bit on lifestyle, environmental risk factors, and how everything comes together, and what the Fatty Liver Foundation is doing to do some really exciting research, cutting edge research in this space. So we're really happy to have you on the line today. Here's who we are. I'll introduce myself first, and then I'll pass the torch to Wayne. So I'm Lindsey Wahlstrom-Edwards. I'm the partnership lead for Sano Genetics. I also have my master's in public health and epidemiology. I'll be talking a bit about the genetics today. I've worked in clinical trials partnerships for the last 10 years or so, and I've known Wayne across a couple of those positions. I'm really excited to be sitting down to have this conversation. Wayne, over to you.
Thanks, Lindsey. Pleasure to be here. Glad you invited us. I'm the founder and CEO of the Fatty Liver Foundation, and I got into this mess because I was an American fat boy, and I ended up with NASH and ultimately cirrhosis. So I don't have a bunch of medical degrees, but I got so upset with what I found in Google and all the rest that the foundation was formed as a way of patient-to-patient curation of information and to try to bring a better patient experience to people that were in my particular position. So I'm glad to be here, and I hope you enjoy the show.
Neeraj.
Hi, my name is Neeraj Mistry. I am a public health physician. I did my medical degree and worked in practice across the transition economy countries as well as industrialized countries in the UK and Europe. A lot in infectious diseases, but then also a lot significantly in non-communicable diseases. That's diseases of lifestyle and diet, everything from mental health to diabetes, hypertension, cholesterol-related problems. As a public health physician, I've often seen that there are shortcomings to our purely medical approach, and we have to address the lifestyle factors, and that sort of led me to pursue a degree in Ayurvedic medicine, which tends to focus quite a bit on lifestyle. So trying to get a more holistic view on patient management and care, both on the prevention as well as the treatment side. I serve as the Chief Medical Officer of the Fatty Liver Foundation.
Thank you. And I realized that I was so excited to get started, I forgot to explain what Sano Genetics does. So I'll do that very quickly. Sano Genetics, we have as our mission to help connect people with personalized medicine treatment. We do that primarily by offering genetic testing so that we can connect people with research programs that are best suited for them and their lifestyles. And we also work with the Fatty Liver Foundation and other organizations to power the research platform for those organizations. So happy to have you all on the call today. Neeraj, do you want to introduce the topic and how we're going to get going today?
Absolutely. Thank you so much, Lindsey. So I'll just very briefly talk about NAFLD and NASH because it sounded like a few of the attendees didn't know what this was. So we are at a perfect storm when it comes to public health issues. And this is not just an issue of very wealthy countries or poor countries around the world. Given that lifestyles and diets have changed all over, we're finding that the rates of diabetes have increased, the rates of overweight and obesity have increased, cholesterol has been on the increase as well. That coupled, those dietary factors coupled with the fact that our lifestyles have changed completely. Back in the day when people used to work the field and have a mountain of rice or starch or some sort of flatbread, those days are gone where people are exerting themselves to that extent. So together with the sedentary lifestyle that people are living, it's sort of starting to take its toll on the body. And what happens is with all those comorbidities, which we call them, it literally converges on the liver. And so there's an excessive in carbohydrate and fat intake, which gets stored in the liver in the form of fat. And it literally fills up hepatocytes, which are liver cells with fat, and that results in non-alcoholic fatty liver disease. And when those fat cells expand, they cause an irritation to the tissue of the liver. Sometimes those cells pop open because they're so big, and that causes further irritation, which results in inflammation. And that's what we call non-alcoholic steatohepatitis. Now, with any inflammation in the body's response to that inflammation is to lay down fibrotic tissue. It's exactly the same. If you cut yourself on your skin, you develop a scab, and that scab is fibrotic tissue. So that's exactly what happens in the liver, where NASH progresses to fibrosis, and fibrosis can progress to cirrhosis, and cirrhosis, which is liver failure essentially, can also predispose to liver cancer. So that's the progression by which that happens. And we're so busy caught up in dealing with the comorbidities that we haven't paid enough attention to this underlying disease that is a point of convergence of all these other diseases. Now, what we're talking about today is also very interesting. Is it the lifestyle that people live in their nurtured environment, or do they have an underlying genetic predisposition that is their nature with the genes they're born that predisposes them to developing these diseases? And this has been a long-standing argument in much of medicine and society, whether it is the nurtured environment or the genetic makeup that causes people to act in particular ways, develop diseases, and sort of evolve the way they have. At some point in the 1960s, there were many scientists who said it's a fruitless argument. Both factors are contributing to the individual's outcomes and how they result in the world. And we're now at a point where we broadly acknowledge that the person's genetic makeup causes them to engage with environmental stimuli in some sort of way that causes some people to develop disease and some people to be protected against disease. And there's many studies done, twin studies, to actually figure this out. However, while we're now acknowledging that, well, the nature, the genetics, work with the environment that result in the outcomes, what we don't know is which genes are affected, and we don't know to what extent a certain genetic makeup exposed to particular stimuli will result in a disease or result in protection from disease. And we know this for a fact that two people of the same type of background exposed to the same environmental stimuli and lifestyle behavioral factors one person might get a disease and one person might not. And so how do we tell the difference between them? And this is what this study that we're embarking on with Sano Genetics is going to help figure out these correlations and attributions between the genetic predisposition that people may have and the environmental factors. So it's a very, very exciting field now that we're able to track this. And we're looking forward to seeing how we can work together to draw these associations and patterns.
Thank you so much. I think what you said is really critical, especially as we get into the genetic risk factor discussion, which is there's a concept in public health, which I know you're very familiar with, called causal pies. So usually when we're looking at more chronic diseases, there are very few conditions where you have one exposure and therefore develop a condition. It takes many pieces to come together. And so what we're doing today is to discuss those different pieces and then hopefully starting to dig in a bit to better understand it. As we get into the conversation on genetics, I want to just contextualize what I mean when I'm talking about personalized medicine. Sometimes we hear the term precision medicine, and I think the easiest way to do that is to use the idea of what we've seen happening in cancer and in oncology. So many of us know people who have been diagnosed with cancer in the last 10, 25 years, probably. And you may have noticed a shift in how your loved ones and your friends are being treated. So 15 years ago, you would probably have chemotherapy, radiation, surgery, or a combination of those things. Now, 80% of Americans who have cancer are receiving some type of personalized treatment, or treatment that has tailored to their mutation. So you've heard of drugs being approved like Tagrisso or Keytruda. Many women who have breast cancer are taking Herceptin. That is a treatment that's targeted to the mutation that's happening within the tumor to block or prevent the disease from progressing, and in some cases reversing course. So what we've done now with cancer, where we talk about estrogen receptor positive breast cancer, HER2 positive breast cancer, EGFR positive lung cancer, we're starting to do that more with chronic disease. And the anticipation is that in the next 5-10 years, we'll look at subtypes of these chronic diseases that Neeraj introduced earlier. So we'll look at subtypes of diabetes, subtypes of NASH, based on the genes that are driving the development of the condition and also how fast it's progressing. And it could be new treatments. It could be plans put in place to help prevent the onset of disease. So that's what I'm talking about when we're talking about personalized medicine. I'm also going to say, before I go to the next slide, that I recognize most of us on the call are likely not mathematicians or scientists by training. So if you are, my apologies, I'm going to take things down a notch. But if you have questions as I go through it, please feel free to ask them, because I'm going to cover a couple of more complicated topics that I think it's important for us to understand. So here's what we know so far about NAFLD and NASH. It's an evolving field. I'm sure we'll know if we did this again in a couple of years, it probably would have a lot more information to share. There are studies that have identified several genes that are associated with NAFLD. So those genes those genes include variants that are associated with the progression to NASH. And there's at least one variant that appears to be protective, which means that you're less likely to progress to having NASH and HCC. HCC is hepatocellular carcinoma, or the liver cancer that we were speaking about. One genetic variant that you may have heard if you're reading the literature is PNPLA3. And in particular, and there's no test, you don't need to remember this, but we're looking at the I148MM homozygous expression. So you don't ever have to remember that again, but there's one specific aspect that we're looking at. It's a big area of focus because the extent to which it increases the likelihood of someone developing NAFLD and then progressing quickly to NASH. And I am going to show you some numbers in a little bit, but that's one of the key takeaways. That's why we're really focused on PNPLA3 as an industry. There are several companies who are working to identify and to test treatments that can help to modulate or impact in some way the genetic variants on health outcomes. And then most importantly, we hear a lot of talk about a tsunami of liver disease that's coming because of the convergence of factors that Neeraj spoke about. If we know who's at risk of developing NASH, of progressing quickly from NAFLD to NASH, we can intervene earlier. And by we, I mean public health professionals, doctors, so we can reduce the likelihood of that tsunami of liver disease coming to pass. So that's why we're talking about the genetics. In the next couple of slides, I'm going to show you some odds ratios. So odds ratios, there are a couple of key things to know. Odds and risk are not interchangeable terms. They're calculated differently. So you cannot determine individual risk. So my individual risk as a person by looking at an odds ratio. The way to interpret the information is that it's the odds of someone developing a condition relative to someone who does not have that genetic variant. So that's what we're looking at on the next couple of slides. When you're reading an odds ratio, the null value, so no statistically significant association, is 1. So less than 1, and the closer you get to 0 in this instance on these slides, it means it's protective. 1 is no significant association, and greater than 1, and the further away from when you get, the stronger the association. If you're out in the world reading literature, it's also important to look at confidence intervals and statistical significance. The next couple of slides, everything is statistically significant, but you may come across articles where something wasn't statistically significant, so you can't just read the odds ratio. So just a couple of things to keep in mind. Again, complicated, but let's break it down. So here are the genes on the left corner, and then across the top we have NAFLD, NASH, and HCC, hepatocellular carcinoma. If you look at the rows that are highlighted here, you see that most of them are pretty close to 1, so with a couple of exceptions. So we have 2 times the odds of HCC with one of the variant, but we're pretty close to 1. But if we look at PNPLA3, you start to see the odds of developing NAFLD are about 2. The odds of developing NASH relative to someone without the variant is 2.5, and HCC is 6. So it's what we see with the progression. Individuals who have the specific gene expression, they are more likely to develop NAFLD, and they're more likely to progress along that continuum. The frequency of the variant ranges from about 17% in African Americans to nearly 50% of Hispanic individuals. So when we get a few slides in, you'll see that we're focusing a lot of our work in the border populations, and there's a reason for that, and that's because of the prevalence. And it could also, this gene could also be explaining some of the differences we see amongst different races and ethnic groups who have similar lifestyle risk factors, obesity, type 2 diabetes, but have different rates of NASH and NAFLD. And then on the bottom, I just want to call your attention to HSD 17B13. Again, no test, it's alphabet soup. Just bear with me on this. But you see that we're below 1 there. So when you're below 1, again, that's protective. And this is a variant that's found in about 5% of the population, which means there's 5% of people out there walking around with this genetic variant doing fine, who are less likely to develop NAFLD, NASH, and HCC. And so there's some study going on there too to understand how that's working and what that gene does to make it protective against developing these conditions, because it could help us to blunt the impact of the others based on what we learn. So again, for the non-mathematicians, non-scientists in the room, what do you need to take away from what we just covered? There are several genetic variants that are associated with NAFLD and NASH. Some make individuals more likely to develop NASH, and at least one is protective. So the effect size of the variants is not equal, which is why we're very focused on PNPLA3 at the moment. We want to understand who's more likely to progress from NAFLD and NASH so that we can create targeted screening and treatment interventions. This is really key, right? And then the third one, I understand personally even that sometimes getting your genes tested and knowing what you're predisposed to can feel a little bit overwhelming or maybe a little bit scary. But when you think about a case of a non-communicable disease, something that's tied to lifestyle, if you understand your genetic risk, it really helps you to flip the script. So instead of waiting to get sick, because everyone in your family has developed diabetes, you're just waiting to develop diabetes, you can understand your risk and have a conversation with your doctor and other care providers in your life and take steps now to prevent or delay it from coming to pass. So that's why we really encourage people to consider genetic testing and to understand risk. Okay, we have a question, so I'm going to pause real quick. Can you have more than one variant? Leo, that's a really good question. I'm not a geneticist. I am more of the odds ratio reading type, and our bioinformatician would be the best position to answer all of the gene specific questions. So if it's okay with you, I have your email and I'll follow up with you after the call. And Deb asked, Wayne, do you happen to know if you carry PNPLA3?
I don't, I haven't been tested for it, but it's unlikely for me.
Okay. Okay. I think that was it for questions. Okay, so I'm going to hand it over then to Wayne and Neeraj.
Well, thanks. I'll talk a little bit about the Sun-1 study. Just a little history, a little personal history, I guess, prompted by that question. One of the reasons that I am so interested in this is because we're quite sure that my grandfather died of liver disease. My dad had diabetes, and although he wasn't tested for liver disease, in hindsight, when he was in the hospital and they gave him dextrose and they caused this real terrific itch, that's a classic liver response to carbs. He definitely had liver disease, and we believe that hastened his death. During the time that I was going through diagnosis, my younger sister passed away from cirrhosis, and she went through all of the really horrible stages of complications that go along with this liver disease, including cancer. So as I got into the area of being an advocate and wondering what to do as a foundation, one of the things that I really was interested in is, could we advance the science, because we didn't believe that things were moving fast enough in understanding the genetics that we have in our family. I believe our family is a classically prone to disease, and we're not in the particularly high risk pool. We're all very Eurocentric, I suppose would be the word. We don't have much opportunity to have the PNPL3 because that's primarily coming through the Latin community. So when we started to think about what we were going to do, do we have some slides on here? There we go. We hatched this idea that we should go out. Well, one of the problems, if you're engaged in this community, you know that we don't look for early stage liver disease in America. Much of the disease is discovered by accident or is discovered when people become cirrhotic or quite ill. And we were not satisfied with that. So we created the SUN study, in which we went out into the Houston suburbs, and we actually tested 1,070 people who were asymptomatic, had never been told that they had any liver problem. And we did fibroscans on them. And we found that, now this is a volunteer group, remember, so they're enriched, but 80% of the people that presented in that study had some liver disease, which ranged from simple fatty liver up to cirrhosis, and none of them knew that they had this problem. And so, could you give me the next slide? The way we did this is we went out into the community. So this is actually different from what most recruitment processes are, because they're based on the doctor's office. Most people that are engaged by medicine are engaged in any kind of analysis. It's because they have become ill. So they're not the population that's running around thinking that they are well. And so we went out into the community, and through a lot of different community-based methods, we actually got a lot of people to come forward and volunteer. So next slide. This is what I was referring to. These are horrendously high numbers. S3, this is steatosis. This is the fat in the liver cell, and there's 3 grades of that: S1, S2, and S3. And S3 is over 60% fat, which is actually a huge fat burden. But 40% of the people that we tested were that fatty. A quarter of them had diabetes. The NASH, or the steatohepatitis, is graded in 4 steps. And F4, of course, is the cirrhosis, which is the most dangerous, but F2 and F3 are different levels of fibrosis. And those are very significant numbers that portend in that F2, for example, those people are going to progress, most of them. And that's the tsunami that's coming at us. It portends a lot more cirrhosis in the population. And most of these people, along with their diabetes, which, you know, the things you hear about are high blood pressure and high cholesterol. So that's the population that we ended up recruiting. And remember that these are people who did not know that they actually had a liver disease. So next slide, please. Most of the programs that healthcare focuses on is the fibrosis, you know, the early stage. There's not a lot of research that goes, there's not a lot of therapy development in the F4, because by the time you get to cirrhosis, it's very, very hard to deal with. And by the time a person is engaged by medicine, they're a fairly small segment of the population today, even though the incidence, which, as we have shown, is quite high. You know, we have 300 some million people in America, and 67 million of them have steatosis already and don't know it. I mean, nobody knows that about themselves. So we get, you know, 20% or 25% of those people will go on to have NASH and ultimately build up into very serious levels of cirrhosis that are coming our way. And this spectrum of disease is what we call the epidemic of fatty liver disease. So next slide. The thing about Sun 1 is that we were so poor that we couldn't do all the job we wanted to do. We were a new foundation and we scraped by, and nobody believed we could do this. And it was a very, very difficult thing for us to get done. But we did pull it off, and again, the study got published, and it got pretty good reviews. I'm really proud of it. But then what's your next act? Well, the next step for us is what we call Sun 2, in which we want to expand the Sun 1 model to 20,000 people, which would be one of the largest NAFLD NASH studies, and to go out into the community and focus again on the asymptomatic population, those people who don't know that they're ill, who don't know that they face this problem. But in this case, our goal is to add genetic testing to our model, because we're going to test all these people. We know that we're going to find a lot of disease. And if we can combine genetic testing with our field data, we believe that we can add to the knowledge about what the genetic markers are that Lindsey was talking about. And that's really an important part of what makes Sun 2 special, because there's a lot of people that are out testing fat people. I mean, there's a lot of focus on that, but tying the science together to lead us in a broader social setting, I think is really important to me. So next slide. So this is a community-based function. We're not brick and mortar based. The Sun study is a mobile system where we actually go into the community and we work with local community organizations and we interact on the ground, and we're down in the mud and the blood where the people really live, and it's not in the sterile environment of the hospital. And we're talking about intercepting this beast before people require medical interventions. And these are just some of the cities typical, just to give you a sense of the kinds of things that we're looking at. The Sun study will be actually broken up into 21,000 patient blocks, and those we'll go 20 different places and 20 different kinds of communities and 20 different situations in order to get a very broad sampling of the tremendous diversity that exists within our country. And I think that's an important contribution that we'll be making. So next slide. We're supposed to turn this over to Neeraj.
Thanks, Wayne. And can I just make two comments after Wayne's presentation? So one, Wayne is the poster child for citizen science, right? And us as doctors and people in the health profession have a certain way of doing things. And the way we do medicine is reactive. We react to people who are sick coming to us, to the health system. What Wayne did is he was proactive as opposed to reactive. He went out there to find the patients. And this sort of change in tone of how we practice medicine and deal with health is critical. And I think understanding people's genetic predisposition is going to help us be more proactive in order to do this stuff. The other thing I think that's really important is that, I mean, for all intents, Wayne talked about his grandfather having some sort of genetic disease, liver disease, and his father had all the telltale signs of liver disease, and he develops liver disease. So there possibly is, on speculation, a genetic correlation or some thread running through it. And immediately one feels, oh my God, I'm doomed. I have the gene, okay? But what is very significant, even in the absence of any medicine, effective medicine to treat fatty liver disease, Wayne, through lifestyle modification, has reversed his disease, okay? He has a liver that is possibly 2 decades younger than his age is supposed to be. So he's managed through lifestyle and dietary changes, has managed to sort of change the trajectory that his genes have determined for him. So that's really, really important that we, while we understand the genetic factors and we understand the lifestyle factors, we understand that they are mutually or codependent. They both influence each other. And so the big challenge we have now is how do we put all this together? Two very disparate worlds, the genes and then the lifestyle. And this is where we've developed the Wellness League. And so people that we will be screening through the Sun 2 study will be entered into the Wellness League. Anyone who has comorbidities or lifestyle risk factors, or even who understand their genetic risk factors by the fact that an uncle or a father or grandfather may have had the disease, can sign up to the Wellness League. In the Wellness League, this is an online community where people can find support on the lifestyle modifications, on recipes, on diets that are liver healthy, on how many cups of coffee are actually beneficial to protect against liver disease, etc. There's also an opportunity to, through a confidential database, enter some of your biometrics and your blood tests, etc. So that's a way of tracking that information. And with the Wellness League, there will be also an opportunity to take a genetic test to understand your genetics. And through this comprehensive confidential database, we will be able to start drawing correlations between gene patterns and the lifestyle factors that we'll be capturing, which would include demographic factors such as age, race, ethnicity, other comorbidities, etc. So it is a huge undertaking, but we are living in an age of big data. And this is the platform which will be accessible for people to join on. And this is where everything is going to happen. So over to you, Lindsey.
Yes. So I was rereading Leo's question. I think I misread it before. So Leo, I think you were asking if you can have more than one variant. So you'd have one expression in your gene, but genes do interact and we don't understand fully how. And so the piece I was going to get back to you on is how, if there's any data yet on how genes interact. I haven't seen it, but that doesn't mean it doesn't exist. So I'll get back to you, but we do all have lots and lots and lots and lots of genes in our bodies. And there are instances with other conditions where we've seen genes can maybe cancel out the effect of another. I haven't seen the data on that on NAFLD or NASH yet. So I will get back to you on that bit, Leo, if it exists. And then Diana asked the question, what is the price of the genetic test for NAFLD and NASH? Wayne, do you want to take this one for the Wellness League?
Well, our goal is that will be free to the participants. We still have to finish raising the money for that, but if they're successful, it'll be a free part of the test. I think that in general, those kind of tests are under $200 US today.
Yep. Okay. Are there any other questions? I think we're getting close to time. Quick round robin for Wayne and Neeraj. If there was one key takeaway from the conversation today, what do you hope it is? And what would you like the listeners on this call, what action would you like them to take?
Oh my, we hope they join. Come join the foundation, get acquainted with the Wellness League, and help us spread the word that early detection and management of this disease is the answer to this epidemic. But and encourage people around you to understand that their lifestyle can be a big hazard for them. They need to be thinking about that.
And I would add, just it's really important where we bombarded with so much information in this day and age to feel overwhelmed. And the important thing is not to feel helpless or hopeless, but that one can take control of one's health. And there are many communities and resources available to provide that support. And so just know that you're not alone in this journey.
Fantastic. We actually, Leo just confirmed that he signed up. So thank you, Leo, for that. I hope everyone else will do the same. I do want to end today just by providing some contact information. If you have questions about Sun 2 or the Wellness League, please contact Wayne and his team at thefattyliverfoundation.org. If you have questions about Sano or more specifics around the genetics, if I can't answer them, I can access people who can. So I'm happy to get you an answer. You can email me at the email listed on there. Oh, one last question. Oh, thank you, Rose. Rose is also signing up. So thank you so much, Rose. If you do have questions after the fact, feel free to shoot us an email. You can also reply back to the invitation and the confirmation email that you received for your registration, and we will get it to the right person for responding. And with that, I think that's it. Thank you so much for Wayne and Neeraj for the conversation today. I know you have a very, very busy day. So I appreciate the time. We will send out this link to everyone after the fact, and feel free to shoot over your questions, and we look forward to staying in touch with you.
Thank you very much, Lindsey.
Okay.
Cheers.